If not, we are behind time. Thank you very much. So I would like to invite Omar Abu Fares, flow diversion in the posterior cerebral circulation.
So dear organizing committee, thank you for the invitation. I'm happy to be today with you at the Balkan Endovascular course here in Bulgaria. My name is Omar Abu Fares. I work as an interventional neuroradiologist in Hanover Medical School, Germany. Today I'm going to be talking about our experience with pipeline Vantage flow diverter in the treatment of posterior circulation aneurysms. And also, if I have a couple of minutes at the end, I'm going to talk about our experience in protective stenting in skull-base surgery. Probably something that not everybody familiar with. So, like most of you know, the pipeline Vantage is a fourth generation flow diverter that was introduced in 2021. And since then, we treated 24 aneurysms in the posterior circulation with this device. The aneurysms that we treated were all of saccular morphology. The distribution you can see on this picture, almost 30% of the aneurysms treated were located at the terminal vertebral artery V4 segment or at the pica origin. 12% of the aneurysms treated were located at the basilar trunk. Almost 30% of the aneurysms treated were located at the origin of the SCA, and another 30% were located at the basilar tip or P1 segment of the PCA. So I'm not going to be talking about these ugly fusiform aneurysms. The aneurysms that we included in our study, they were all of saccular morphology. So as you can see here, 24 aneurysms treated in 22 patients. 4 aneurysms were previously coiled for subarachnoid hemorrhage. In the posterior circulation, we're dealing with smaller vessels. So you can see here that the median vessel width was 3.5 millimeter and the flow diverter width median was also 3.5 millimeter. The grade of aneurysm occlusion at the radiologic follow-up of 14 months was as follows. Class 1 or complete aneurysm occlusion was documented in 50% of the patients or the aneurysms treated. Class 2 or neck remnant in 41%, and class 3 or aneurysm remnant was documented in 8% of the aneurysms treated. Here you see the list of complications that we had. 3 complications led to MRS shift from 0 to 3, 0 to 2, and 0 to 1. One of the complications was brainstem infarction after the treatment of basilar bifurcation aneurysm. The flow diverter was implanted from the PCA to the basilar trunk, and a week later the patient suffered a brainstem infarction that led to MRS shift from 0 to 3. One patient suffered a spontaneous cerebral hemorrhage 1 month after the intervention for the treatment of SCA aneurysm. Also here, the flow diverter was implanted from the PCA to the basilar trunk, and a male patient suffered a compartment syndrome after the radial puncture. This patient delivered the wrong heparin dose, not 3,000 but 30,000, and this led to this complication. I want to show you a couple of the cases we treated. This is a patient with glossopharyngeal neuralgia. She had lobulated pica origin aneurysm. This aneurysm is really hard to treat with other devices, but when you put a flow diverter in the terminal vertebral artery, then you can fix the problem. You can see in this TOF MRI, the one almost in the middle, that the pica and the sac of the aneurysm, they have a flow signal in them, but on the right side image, 3 months after the procedure, you can see that there's no more flow void in the aneurysm sac or in the pica. This is another, this is another good indication for flow diverter sidewall aneurysm of the V4 segment, and on the right side you see the follow-up images with a small neck remnant. This patient had basal trunk sidewall aneurysm. You see in the middle picture how the contrast media stagnation after flow diverter implantation. The MRI TOF, you cannot tell if this aneurysm is shut or not, so you have to perform DSA, and then you can see on the right side that the aneurysm was excluded. This was a young patient with the SCA aneurysm. It was a small aneurysm, but the patient, she wanted to have the treatment, although the aneurysm was only 2 millimeter, so a flow diverter was implanted from the PCA to the basilar trunk. As you can see on this coronal reconstruction, there is an instant stenosis inside the stent, but this instant stenosis resolved spontaneously on follow-up imaging. And a fetal PCOM took over the right PCA. This was the only case of instant stenosis that we documented after treating flow diverters with Advantage in the posterior circulation. In contrast, we published our data on aneurysms treated in the anterior circulation, and there we found a 10% instant stenosis. This is a very complex aneurysm, basilar tip. This patient was coiled on a PCA aneurysm in the 80s. You can see the basilar tip aneurysm. You can see the fusiform SCA aneurysm on the right side. A pipeline Vantage was implanted from the right PCA to the basilar trunk. This patient decided to stop the medication 1 year after the procedure. On the right side, you see the first follow-up, and this is the second follow-up. So to wrap it up, pipeline Vantage seems to be safe and effective in the treatment of saccular posterior circulation aneurysms. We had a high adequate aneurysm occlusion rate of more than 90%, 8% ischemic complication rate, 1 hemorrhage. Basilar bifurcation aneurysm had the lowest complete aneurysm occlusion rates in all the posterior aneurysm locations of only 33%, and they had higher complication rates compared to other locations. Instant stenosis is very rare, only 4%, and fish mouthing was not observed. I would like to show you maybe just a couple of slides about this skull base, our experience with protective stenting in skull base tumors. So when you have large tumors like the one shown here, this is a large paraganglioma that involves the ICA or the large vessels in the base skull. It's really hard to treat or resect these tumors without sacrificing the vessels involved. So what we offer to our surgeons is we put stents or flow diverters in the ICA in the segments that's involved. We wait 3 months, neointima is formed, and then the patient can be operated. These are some of the indications. This is not a complete list, but these are some of the indications or the patients that we treated. Most of the lesions are benign, like meningiomas, schwannomas, inverted papilloma, or paragangliomas. We use different stents like Silk, Fred X, Pipeline, Vantage, and Shield. If you look at the flow diverters sizes, you can tell that these patients need longer flow diverters or stents and larger sizes. So I want to show you just maybe one last case. Maybe this one. This is a 42-year-old patient with a large paraganglioma on the right side. As you can see on the left image, the paraganglioma involves both ICA and external carotid artery. Here you see the images of the common carotid artery, AP and lateral. You see the large tumor blush. So on the right side, you see what we did. Pipeline Vantage was implanted, and inside the Pipeline Vantage, a carotid wall set was also implanted. The patient comes 3 months after the therapy, and what you can see here is the flow diverter, the lumen of the vessel, and the neointima. This patient, or the tumor, was embolized before with particle embolization before the procedure. And here you can see how the... could you please play the video? Here you can see how the surgeon, he's dissecting the vessel wall. This white, what you see now, is the flow diverter, and inside the flow diverter you can see the neointima, and the surgeon can resect the tumor away from the vessel wall. This is the CT and MRI images after the procedure. You can see the stent, you can see the fat tissue that was implanted in the soft tissue defect. So this is another patient with neurofibroma, was also stented. So in conclusion, this protective stenting is safe and it's very helpful for our surgeons in skull-base surgery for vessel preservation. And we used to implant other stents like Leo stents or laser cut stents, but the flow diverter is definitely the better stent. That's the feedback we got from our surgeons. Thank you.
Thank you very much for your wonderful presentation. Any questions from the audience?
Can I ask you, do you think a cover stent will do the same here? A covered stent?
Like papyrus, or what are you thinking about?
Maybe a lot of more intimal hyperplasia and...
The thing is, our surgeons, they stop all platelet medication before the therapy. So 3 months later, no aspirin, no Plavix, nothing. And then they perform the surgery. So I think it could be a little bit more risky, because when you have a stent with more material, it probably is maybe safer, but it's probably more thrombogenic. I don't know.
The trick is here is how long you can wait to get a good intimal reaction. So whatever it is, cover or non-cover, if it is the tumor, let you wait. Yeah, that is an option. Especially cranial best surgeon now, trying to protect the vessels. But I believe if there is a good collateral flow, occlusion of the parent artery is still a good option than this.
Yeah. Well, we try to do occlusion tests, but not the balloon occlusion test, because it has low sensitivity, of course. But you're never sure even if you see collaterals, you're never sure that the patient is not going to have a deficit if you sacrifice the vessel.
No. That is not like that. You know, if you have a good collateral test, with balloon, we have instrument like that. And you will be sure that there will be no deficit after occlusion, and you will be the guy who did the occlusion, not the surgeon. So we are doing this technique for years, for decades. So in that case, I think that is good. Time to time, I'm also doing it, if there is no collateral. And if the surgeon doesn't want to occlude the vessel. But we should not forget that parent artery occlusion in that tumor situation is really a good option than this.
Well, the thing is, you know, the clinicians that we deal with, they always try to preserve the large vessels, because most of these patients are young, so most of them were less than 50 years old, and we try to preserve as many vessels as we can, and some of them don't have these collaterals. So.
That group is okay.
Yeah.
The same story for aneurysm, why we are occluding the parent artery. That
Exactly.
they are also young, they also have a long life expectation.
Yes.
But there should be a balance in between the tumor, parent artery occlusion, and protection. But thank you for showing this, because I have this almost the same case that you can see the stented artery with bare eyes. Now microscope with here is a whole big hole, and you can see the stent. Just because of the good intimal reactions, it's not bleeding at all. It is interesting to see.
Thank you once again. There is a question.
So Omar, this is the only place, the cases that you showed, ironically speaking, this is the only place where we can actually would love to see intimal overgrowth over the
Yes.
stent, right?
So advantage is perfect
You want to
here.
see the expected complication of full eversion inside ICA.
Yes, as I showed you in the picture, you know, you can see very nice intimal hyperplasia. So we know that the 3rd till the 6 months, that's where you see the most of the intimal hyperplasia, and that would be the perfect timing for the operation. But on the other hand, they have to stop all the medication and do the surgery. So till now, it went well.
Thank you.
Thank you once again.